the first one topic, that is Principle of Management of Open Fracture of Tibia, will be deliberated by Dr. Shankar Kumar Rai, who is an associate professor and head of the department in the Sylhet MAG Osmani Medical College Hospital. And the second topic is compartment syndrome, which will be deliberated by Dr. Muhammad Sadiqul Amin, who is an assistant professor in Sheikh Saira Khatun Medical College Hospital in Gopalganj. Let's talk about some information about AOA Alliance. AOA Alliance is a non-government, non-profitable organization which are dedicated purpose is to dedicated to improving the fracture care through the local capacity build-up. So initially, the AO Alliance was AOSEC, that is AO Socioeconomic Condition. At 2015, is converted into AO Alliance, which is initiative by AO Foundation for the low and medium income countries. And what are the scope and activities of the AO Alliance? They provide fracture care as well as neglected post-traumatic care by using separately or in combination with some activities, so that the AO Alliance provides, they have scope for education, have scope for fellowship, have clinical researches as well as clinical service support. For the purpose, what is the purpose of the AOLS? It is to build up the local capacity with as the highest priority and applied in comprehensive longer term programs to make it sustainable. So, dear participants, you have to maintain the you have to give your feedback during the presentation in using the chat box. Please mute all the microphones and please give your feedback or any question by using the chat box. Now I am requesting Dr. Shankar Kumar Roy to start his talk about the principle of management of open fracture, and I am requesting you to sharing his screen. Dr. Shankar Kumar Roy.
Okay, good afternoon.
And
thanks all the yes, thanks all the participants being here. I wish you are all well in difficult time. My presentation is Principle of Management of Open Fracture Tibia. It's difficult to tell within 20 minutes, but I'll try my best. Let's presentation. What's the learning objectives of these presentations? Is the assessment of the injury, immediate management, radical development, and fracture stabilization and wound closure. These should be our learning objectives. What's the open fracture? We know everybody the fractures which is direct communication to the external environment. This is the open fracture. Incidence is one of the commonest long bone fractures. That's a 2/1000 population, and 1/4 are the open. So it's not less in amount. Mechanism of injury, there's a two mechanism, the high energy force and the low energy force. High energy force occurs in the road traffic accidents, and low energy force occurs in the sports injury actually. There's some associated injuries with this type of fractures. That 30% patients have the multiple injuries, and you should consider these proximal and distal fibular joints, knee injuries, ligamentous knee injuries, and of course ipsilateral femur fractures we should consider regarding the management of these things, of these associated injuries. Classification is very much essential to know the classification of the open fractures. Why you know it? You know, for communications between the healthcare professionals and we can formulate our treatment plan by this classification. And of course, the important things is the limb salvage procedures or decision making, the prime amputation or limb salvage is the important things. And another important is a detailed audit of care to ensure optimal management. So what's the classifications? There are three systems here. There's a grading system, scoring systems, and comprehensive system. Grading systems, we know are well known the Gastrell Anderson classifications with other classification also. Actually, this is a focus on the severity of the limb injury mainly. And scoring systems is the Mangal extremity scoring system, NACE score, and another also there is the amputation score, decision making procedures. I told it earlier. And comprehensive system, these are newer systems. There's two systems, our systems and Ganga Hospital score. Grading system, the well-known Gastrell Anderson classifications. Actually, the emphasis on the two things: soft tissue injury and contamination of the tissue, and also there is some fracture pattern of the simple or comminuted fractures. Its emphasis is three things also. At a glance, there is the Gastrell Anderson classification. I'll not go for details of this classification. Actually, this classification help us some prognosis outcome of the infection rate and the fracture healing. And infection rate is gradually increasing in grade 1 to 3, up to 1 is 0 to 2%, and 3B, C up to 50%. And fracture healing gradually increase in the time of the fracture healing time. And also 3C, there is a, if there is a 3C, there is the amputation rate is 50%. So it gives some details of the clue about this, but its disadvantage is that we should classify this after development and primary wound care. It not in the emergency room, in the operation theater after these things. So Mangal extremity scores is the scoring systems. We know everybody that the Mangal extremity score deals with four things: the skeletal and soft tissue group, shock group, ischemic group, and age group. There, the ischemic type is more than 6 hours. We add 2 points. These are important things. Mangal extremity scores, the 0 to 11, the scoring systems. A score is 7 is greater, is predictive for amputations, and is some specific but lacks some sensitivity. So newer system, the Ganga Hospital severity score, ISS score, is Rajshekaran 2006. The proposed fracture gastrula type 3 and 3 open fractures. It's highly specific, is better, much better predictive for amputation. What they tell that they already deals with four things covering structures, that is skin and fascia, skeletal structures, bone and joints, functional tissue, the muscular tendinous and nerve units, and comorbid conditions. They introduce these two things here: nerve units and comorbid conditions. So it is more reliable in the decision making procedures, amputations, and limb salvage procedures. They introduce Gastrell Anderson classification. They did not introduce these two things. Comorbid conditions, that's the injury if development interval more than 12 hours. If patient is severely contaminated wound, patient is elderly more than 65 years, patients have increased anesthetic risks, the high diabetes mellitus, polytrauma patients, and low blood pressures and compartment syndrome. Ganga Hospital scores, there are four groups that told that a score is 14 is greater is indicator for amputations. So management is the important management how we manage our patients in the open fracture of tibia. Actually this is a multidisciplinary approach, and then we need vascular surgeon, plastic surgeon, and trauma surgeon, and rehabilitation facilities. We everything the coordinated principles, and our goals is to the chronologically first the preserve life, the limb, and then function. So principle of treatment with how we prevent the infection, coverage of the soft tissue, and fracture stabilizations. Preserve life, how the primary survey, that's we know it everybody ATLS system by airway, breathing, circulation, and disability. We know it go for details in this management. Or in our main, we know the open fracture is actually this is a high risk for infection. So our main motto is to prevention of sepsis. There is three study here. There in the left side of my slide. There in all studies, they conclude that one thing there that most infections are the pathogens are the hospital acquired infections. I mean, they told that the 92% the open fractures are occurred in the patients was in the hospitals. So you should the more the patient we stay in the hospital, there's a chance of infections. How you prevent the infections? The 14th antibiotic, tetanus prophylaxis, debridement and redebridement, and coverage of the wound. There's a antibiotic recommendations here. There's a grade 1, grade 2, there's first cephalosporin, grade 2 you can use gentamicin also, but grade 3 in gentamicin. And is that a firm and contaminated wound, we should include the penicillin here. The stance of tetanus for tetanus. Local antibiotic therapy is the important modality of treatment nowadays. We are using in many centers. Its advantage is that increase 200 folds of increase local concentration, but reduce the less systemic effects. So we can use it, popularly use it. And there are just vancomycin or aminoglycin, this and tobramycin. There are many local antibiotic therapy. That's there's a study here that if you use single antibiotic, intravenous antibiotic, the infection rate is 12%. If you use systemic plus local PMA beads, the infection rate is 3.7%. Yes, primary wound care. The important step of the management of the wound. We do it in the picture is just a photograph of the pre-lavage of the how you pre-lavage the wound in the emergency room. But we can use lots of fluid to decontaminate of our wound by soft swab. We remove the blood stains. There we remove the debris. We remove the visible foreign body. So is the important steps. So that's for the decontamination. And then irrigation, we use actually sterile solution. According to the grading, 3 to 10 liters solution we need is to solve decontamination of the wound. If necessary, we just extension of the wound. And the important sentence that the solution of pollution is dilution. So the more you fluid we use, the prevention is we can prevent our infections. Another you can use by soft brush but for decontamination of the wound. Yes, we can use for decontamination some antiseptic solution, that's antibiotic and some surfactants, that's the povidone iodine, the picture here. But there is some disadvantage to use this because it increase the host cells injury. Not routinely use this. But if you use in povidone iodine, that use the non-alcoholic product should be used here. But if there is a severely contaminated wound, we can use the surfactants like the soap and the hexi scrub like the solutions. Debridement is the important step of the management of the fractures, and it's told that it's not a science, it's art. And experience with time. That means the experience, the more the experienced surgeon that they do it, that a good debridement they can do it. And sequentially, it should be from superficial to skin to bone. And of course, you should check the blood pressures and keep their tourniquet ready for if necessary. We should use this. There's a two picture, the pre-debridement and after debridement. The how look the after debridement, and debridement should be this aggressively of the all devitalized tissues. Bone debridement, the bone all of devoid of soft muscular attachment or soft tissue attachment should be removed. But in exceptional is there articular surface the fragments, we can keep it for this redebridement. These are the important things. Actually, in the first debridement, some tissues becomes confusion to, especially there's there's a viability of the marginal tissue. So we should plan for redebridement and for secondary closure. Stabilization of the fractures is important. Why you didn't need it? Because we restore the length and rotation and angular alignment, and also there's the healing of the soft tissue. and we can decrease the fracture fragments motions, so that decrease the soft tissue damage, decrease pain, and permits the mobilization of the joint, so that they decrease the stiffness of the joints. What we do stabilization we did, there are four things: external stabilizations, intermedullary stabilizations, external fixation, uniplanar, multiplanar, and plate and screw. Extraosseous stabilization actually used in low-grade open fractures. We can use in plaster or weight bearing or splint, weight bearing cast or splint. Intermedullary stabilizations is the excellent results told us in type 1 fractures, but if there's in some specialist center by trauma and plastic surgeons available, we can use in type 2, 3, and 3B fractures. External fixation is actually this widely used this fixation. We use it, and we can. This the important is the advantage is the tracing and surveillance is possible, but the disadvantage is that the malunion and secondary procedure always needed for this. If we fix it by external fixation, conversion of other procedures needed, and the most common complications is the X-fix is the pin tract infection. Plate fixation, actually we do not use it primarily because there is the extensive soft tissue dissections and devitalization of the tissues, in increased chance of superficial and deep infections compared to other techniques. Yes, filling the bone defects, which is important things. We can bone defect the filling the bone by PMMA, aminoglycid, and vancomycin, that we can use the bead pouch. There, here my picture shown there, the bead pouch and solid spacer, and by destruction of osteogenesis and bone graft. Soft tissue cover. Soft tissue cover is a primary closure. We should advocate not to use in the primary closure because uh, all the even type 1 fractures, the all open fracture is the prone to infection. So we should advocate the delayed primary closures or by skin graft or flaps. And our coverage, our goal will be should be within 5 to 7 days cover the wound. Another soft tissue cover is the Beckham assistant closure, which is the newer modality of treatment now using, especially they are using as plastic surgeon they are using, but orthopedic surgeon are using in some centers. This is the negative pressure with the decreased extravascular fluid and decreased the increased microcirculation, and also the reparative granulation tissue regenerate. So decrease wound contraction, so that we can use the skin flap or use the skin graft or flap. And this is the much benefit. Rehabilitation is the important. Rehabilitation of the limb, rehabilitation of the injury of the patient is important. Rehabilitation of patient is very much important because the multiple procedure needs of these patients become demoralized, and we orthopedic surgeons has a role, important role to boost up patient's mentality as a motivator, and also patient we should some sympathize to our patients, and of course the patient's family should come forward to our patients to become to return is the pre-injury states. So it's a very important step for rehabilitation. And above all this management, some drastic complications may occur. There's the complications that the non-union, malunion, infection, compartment syndrome, fatigue fractures, hardware failure, chronic osteomyelitis. So we should manage this. This is my last slide. So my take home message here: does it treat all open fractures should treat as an emergency. ATL is the important role here. Debridement and redebridement, stabilization, fracture and soft tissue, early closure, and antibiotics. This we should if we follow these rules, we can decrease our complications. We can manage our patients efficiently. Thank you, everybody. Thank you, patients hearing.
Thank you, Dr. Shankar Kumar Rai, for your nice and elaborate presentation on principle of management of open fracture. So now the part for question and answer session. Before going to that, we'd like to invite the CEO of AO Alliance Foundation, Dr. Claude Martin. May I ask Dr. Claude Martin to give his comment regarding our today's webinar. Just a minute. Okay, I think he's not available. Okay, we can go for question and answer session. First of all, I am asking Professor Dr. Hassan Masood sir. The question is that in what forms of local antibiotics are used and how effective they are?
Yes.
Can you get my question?
Yes, excellent question. You can just utter the two forms. One is the commercial form. The commercial form, the PMA beads, that means polymethyl methacrylate beads with aminoglycosides, means gentamicin. So gentamicin beads are available, commercially available. You can use this, or locally we can make the preparation by adding vancomycin in 40 gram of bone cement, 40 gram of bone cement. We can add 1 gram of vancomycin and make the locally make the some small amounts of beads and take it in a surgical wire and put it in the wound, and we can use it for 6 to 8 weeks also according to the need. And Dr. Shankar in a slide has presented that if you use only systemic antibiotics, the chance of infection is 12%, and if you use systemic antibiotics with the local antibiotics, the chance of infection is 3.7%. Thank you.
Okay, thank you, sir. That means it is very much effective, the local antibiotics, sir. The second question is to Dr. Farooq Kashim, sir.
Okay.
Okay. So, can you hear me, sir? So, if a patient has visited in other hospital before coming to you, do you take care of MRSA positive cases or other hospital-acquired infection preventive measure?
Yes, in that case, of course, we have to consider that, because initial development is very important, we all know. So we have to get detailed history, and we have to assess the timing and everything, and then we should proceed accordingly. And as we all know, MRSA resistant bacteria are very difficult to eradicate. So in that case, I think what Dr. Hassan Masood has already said, that is locally impregnated, antibiotic impregnated beads are very important, which we can easily, we are actually making in our OR with polymethyl methacrylate cement and vancomycin. And sometimes when vancomycin is not available or it is costly, we can use gentamicin as well.
Okay, thank you, sir. The next question is to Dr. Fazlul Haq Kashim. Please unmute yourself. Oh, okay. So, for how long antibiotic has to be prescribed according to Gastillo-Anderson classification system? So, question is that according to Gastillo-Anderson classification, how long antibiotic should be prescribed?
What we read in the book and the scenario in Bangladesh is different. So in book, it is only for 48 to 72 hours. But in Bangladesh, what we practice, after control of infection, we use at least 7 days the antibiotic more. As because our environment is not that pollution free. So whatever maybe it is 1, 2 or 3, after control of infection, we will continue further 7 days to keep this infection control. This is what we practice in Bangladesh.
Okay. Thank you, sir, for your answer. The another question is I'm giving it to Dr. Shankar Kumar Rai. So, Dr. Shankar Kumar Rai,
Yes.
if we cannot close the wound within 7 days with an external fixator in situ, so what can we do?
Yes, the important questions. We in our practice we cannot remove the external fixator within 7 days. So if it is not possible to remove the external fixator with 7 days, we can keep it. But if you can keep it for further 2 to 3 to 4 weeks also. But if during removal, we should check up this. We should also check up the pin track. If there is a pin track infections and there is any other infection, we should treat it. Of course, and pin should be removed and new pin also introduced. Also, there is some options we should switch over this. We just remove this. Give this. There is a destruction of stage Elizarov procedure. We can use it, and also we can second procedure. So the secondary reconstructions. We just start our secondary reconstructions.
Okay, I think we have got the answer. Another one question to, I think, Dr. Farooq Kashim sir. What is the role of external fixator? Oh, sorry. What is the role of the Elizarov external fixator in open fracture of tibia? When should we do reconstruction? If we do Elizarov external fixator, which one is better, Elizarov or modular X-fix?
That's a good question. It actually, it depends on the center, on the person doing the trauma. So I think it's a debatable matter, but what we see actually in everywhere, the modular X-fix is using most in many centers. And of course, if it is our Professor Barisar, then he would have done it with the Elizarov X-fix. So Elizarov, of course, it has got a role in maintaining the length and also caring of the soft tissue. But initially, in my view, I would like to have modular X-fix.
Okay, thank you, sir. I think Dr. Fazlul Kashim sir. Yes, Dr. Kashim sir. Dr. Yes.
Yes, I want to supplement that it is the modular or Elizarov. It is two things. Elizarov is for the definitive treatment. If you want to treat the open fracture of the tibia, definitely only by the Elizarov by X-fix, then you can use the Elizarov. And if you can treat this for a temporary measure for the time being, then after that you will convert it to IM nail or plate or other device. Then for the temporary measure, no need to use the Elizarov. This is the thing. Elizarov is for the definitive treatment and modular is for the temporary treatment.
Okay. So another question regarding the recent guideline. Dr. Hassan Masood, sir.
Yes.
What is the recent guideline protocol for internal fixation of fracture in case of open fracture?
Yes, thank you for the question. If the patient comes to you within 6 hours of the injury, then you first assess the wound and like the comprehensive score by MES or by Ganga severity score. Then, if possible, the modern guideline is to use the internal fixator, if you can use it. And in the same sitting, if the plastic surgery is needed, you can do it. So modern guideline is within 6 hours. If the patient comes to you, you can use the internal fixation.
Okay, up to which type we can fix, sir?
Definitely, Gastilo 3C not, and 3B you have to judge because the Gastilo is only grading, but you have to use the comprehensive scale. That means the Ganga injury severity score, and if it is feasible, the total scoring system is below 14, then you can attempt for the internal fixation. Otherwise, it is not suggested.
Okay, thank you, sir. And to Dr. Shankar Kumar Rai, in which type of open fracture local antibiotic is used and when, either in the first stage of debridement or in which stage of debridement we would like to use the local antibiotics?
Okay, actually, local antibiotic is used. We can, if we see that there is a, I told you the bead coach and there is a bead spacer. If need to remove there is a long-term infection, wound is not covered, is not possible earlier, so we can use it. There is many techniques here. There's the Masiko techniques in the local antibiotic. We can use these techniques. And there's the important things that we can use this local bead ports and bead spacers by aminoglycosides as gentamicin, topramycin. There's many things here, and the wound mainly that the three we suggest for the 3B and 3C. There is a severely infected wound. The local antibiotic, systemic antibiotic is not alone is to eradicate the wound. Then we can use it we can use it local antibiotic local antibiotic with system antibiotic. Thank you.
Thank you, Dr. Shankar Kumar Rai. I think we have not much time for this presentation because we have another presentation of compartment syndrome. If we have time later on, we will discuss the rest of question. There are more questions. I would like to invite Dr. Sadiqul Amin. Can you share your screen, please? Yes.
Another profile, please. I have another profile, please.
Okay. I have unmuted.
Okay, thank you. Can you hear me clearly?
Yes.
Yes.
Please share your
Thank
screen.
You. Yes. Good afternoon, everyone. Welcome to my presentation about the compartment syndrome, a very important topic and a headache of every orthopedic surgeon or trauma surgeon in some situation. The learning objectives of today's presentation are to know the importance of compartment syndrome, to know how to diagnose it, to know how to treat it, and to save the limb and the life. The definition: an elevation of interstitial pressure in a closed osteofascial compartment that results in microvascular compromise is the compartment syndrome. And at this stage, we should all remember the contributions of Richard von Wachmann, the German surgeon, the most prominent surgeon of his days. He described the Wachmann ischemic contracture in 1881, and he has many other contributions. Actually, in 1906, Hildebrand first used the term Wachmann ischemic contracture, and he suggested that increased tissue pressure leads to ischemic contracture. And in 1909, Thomas said the fracture is the primary cause for compartment syndrome. And in 1914, Murphy said the fasciotomy prevents contracture. And in 1967, Sedor and Kelly said that all compartments should be released to heal the compartment syndrome. Now let us come to the types. Acute compartment syndrome. Acute compartment syndrome is the true orthopedic emergency, and it is caused by severe injury and can lead to limb and life-threatening condition. Other types of chronic compartment syndrome, which actually occurs in athletes and due to chronic exertions, it is not a medical emergency. And there is also abdominal compartment syndrome. Now let's come to the etiology. The etiology is basically of two types, either decrease of the compartment size or of the increase of the compartment content. And what are the causes of decreased size? The tight closure of fascia, tight dressing and cast, circumferential burn scar, and prolonged inappropriate body position like in operating table. And the causes of increased compartment content are fracture. And we must remember that we have a fallacy here. We often think that only closed fractures develop compartment syndrome, but we should remember that open fractures are not caused by the surgeons. And often some compartments are remain closed and they can develop a compartment syndrome. Next, the hemorrhage, vascular injury, and coagulopathy. And then increased capillary permeability caused by trauma, burn, and snake bite. Manipulation and traction during external fixation and intermedullary nailing insertion can also cause compartment syndrome. Let us see the compartments of the upper limb. In forearm, there is the anterior compartment and posterior compartment. And in the arm, there is also anterior and posterior compartment. And in the lower limb, the thigh has three compartments: the anterior compartment, the posterior compartment, and the medial compartment. And in case of leg, the most problematic one and which we face most, the compartments are anterior, lateral, superficial posterior, and the deep posterior, which we often miss and suffer a lot. The classical vicious cycle of the pathophysiology of compartment syndrome, here we can see the direct injury causing the tissue edema, and again arterial damage leading to ischemia can also leads to edema and developing the compartment pressure and compartment syndrome. And it again reduces the blood flow to the tissue, leading to more ischemia and more edema and more increased compartmental pressure. And here is where we have to do it. We have to do the fasciotomy to release the compartment and to relieve from going to the vicious cycle. We have to break the chain here. The Whiteside theory says the development of a compartment syndrome depends not only on intra-compartment pressure, but also on systemic blood pressure. Because when a trauma patient comes, his systemic blood pressure also falls. And to maintain the muscle tissue or tissue perfusion, that is MPP, the difference, it is measured by the difference between the diastolic blood pressure and the intercompartmental pressure. It is also called the delta pressure, and it must be kept to more than 30 millimeter of mercury. And we also should remember that compartment syndrome is also a pressure time phenomenon. Not only the pressure is the factor. And irreversible damage starts after 6 to 8 hours of increased pressure. But in the accident scenario, we do not actually know when the pressure reached that critical level and when the clock started ticking. The patient usually come to us with the history of high velocity injury, high energy transfer injury, metaphyseal fracture, or crush injuries. And usually these sort of limbs swell the limb with tight, tense, and tender compartment. And the classical P's of compartment syndrome are the 5P, or some say 6P, and newer we should say, I think, 5P plus P. The number one of the P is the pain, and is the most important thing. And classically it is said that pain, pain, and pain. Pain out of proportion, which is not relieved by standard analgesics, and excruciating pain on passive stretching. These two are the most important symptoms in diagnosis the compartment syndrome, and pain is the single most important symptom. Among the others, paresthesia due to compression of the nerve by edematous tissue, pallor, which is actually not very difficult to determine in our dark-toned people of our country. Paralysis and pulselessness is also there, but pulselessness, there is some problem about the pulselessness. Someone think it is very important, but it is said that it is last and the least. When the pulses are diminished, damage has already been done. And the sixth P, which is now becoming more and more important with the newer and newer devices to measure the intercompartmental pressure. In this picture, we see a machine developed by Synthes, and some other machines are there, like this, the traditional wick catheter with connecting it with a manometer. It is also used in some centers of our country. And the Stryker compartmental tissue pressure monitor and Compass pressure monitor. In diagnosing compartment syndrome, there is some points which may lead us to dilemma. That is, we are looking for pain, but the patient, if the patient is unconscious, how can he help us in determining the diagnosis? And if the patient is under anesthesia or very high grade analgesia, or we should be careful about it. And if we miss the diagnosis and we deal there or sepsis leading or multiple organ dysfunction syndrome, even life loss. And at least it may develop Volkmann ischemic contracture or limb contracture. Now come to the treatment. Immediately what we should do, we should remove all the plaster cast or dressing completely, and any tight clothing should be released and limb elevated at the level of the heart. Any hypoxia or hypovolemia should be corrected by correcting the hypotension and oxygen supplementation. And the definitive treatment of the compartment syndrome is fasciotomy and fasciotomy. And we should say the treatment of compartment syndrome is fasciotomy, and treatment of impending compartment syndrome is also fasciotomy. If you think about it, do it. And these things should be remembered, that incision should be given ahead of time. And we should save the superficial peroneal nerve laterally and saphenous vein and nerve medially in case of lower limb. And in case of upper limb, the bicipital aponeurosis and the carpal tunnel must be released in forearm. And we should ensure the release of all the compartments. And here we can see the usual and standard incision lines in, for releasing compartments. In leg, the lateral incision is between the shin and the fibula. And the medial side, we should not give incision to the on the shin, avoiding the shin, about 2 centimeter below.
I think Dr. Sadiqul Amin. Network is dropped. Dr. Sadiqul Amin, can you hear? I think there are some technical problem for or network problem from Dr. Sadiqul Amin. So in the meantime, I think we can take question about open fracture. So I think we can take question. Dr. Fazlullah Kashem, sir. Yes.
please.
So
Question from the open fracture of
yes. So someone, the question is that after any flap coverage, how long should we wait for internal fixation? Did you get me, sir?
Who will answer? Who will answer?
Okay, you.
Oh. After flap coverage, you to judge. After it is viable and it is the wound is covered and it becomes okay, and the infection is
I cannot hear you. You are not audible.
Sure.
Hello?
Can you
Hello?
hear me? Can you hear me?
Hello?
Can you hear me? No?
Dr. Fazlullah Kashem. Hello? Dr. Sadiqul, can you hear me?
Now can you hear me? Can you hear me?
Dr. Fazlullah Kashem,
Oh, sorry.
we cannot hear you.
Okay. You ask the question to someone else.
Hello?
Can you hear me?
No. Dr. Sadiqul Amin, are you, is it okay? I'm sorry. Yes, I'm giving to another one of your
Second
device.
profile, please. Iman, second profile, please.
Where is it?
Second profile, my second profile.
Hello, Dr. Sadiqul Amin.
Muhammad Sadiqul
Hello?
Amin.
Hello?
Can you hear me clearly in this? Then I should carry on with this.
Dr. Fazlullah Kashem, can you hear me?
Yes, I can hear you. Do you hear me?
But I can't hear.
Yeah.
Yes.
Dr. Iman, should I continue?
Yes, your screen share is on.
Can you unmute my second profile?
হ্যাঁ সাদিককে বলতে বলো খাড়া
Please unmute my second profile. Hello, can you hear me now?
Hello.
হ্যাঁ তোমার নিজের আনমিউট করে কথা বলো
Please unmute
Sir,
করেছি।
unmute করেছি স্যার। Hello, sir. Can you see please?
Dr. Sadiqul Amin, can you hear?
Yes, I can hear you. Can you hear me? Can you hear me? Hello? Hello? Hello?
তুমি সাদিকের কথা শুনতে পাচ্ছ না
Hello? Dr. Iman?
তাহলে তোমার প্রবলেম হয়েছে হ্যাঁ
স্যার আপনি কি আমার কথা শুনতে পাচ্ছেন?
তুমি সাদিককে কন্টিনিউ করতে বলো তুমি বলো ও শুনতে পাবে
স্যার কি আমাকে শুনতে পাচ্ছেন? Sir, can you
Dr.
hear me?
Sadiqul Amin, you can start.
Yes. Yes. Okay. Did you see this slide in my presentation?
yes.
Yes. Okay. Yes. Here we can see the fasciotomy incision of the arm and forearm. And after giving the incision, not giving the incision is enough. Aftercare of the wound is also important. After the release of the compartment, skin should be left open and negative pressure wound therapy, that is VAC therapy, should be used. Stabilization should be done temporarily or definitively according to situation. And of course, the second look surgery should be done within 24 to 48 hours. And we should think at the early stage about the skin graft or gradual closure in 2 to 3 weeks. Here in this picture, we see a fasciotomy incision with with stabilization with external fixation and application of negative pressure wound therapy. Though fasciotomy is a limb and life-saving condition, but still it is the procedure not without complication. It may give rise to muscle weakness, chronic venous insufficiency, tethered scar, impaired sensation, ulceration, and cost of the person, of the family, and the society. And with the orthopedic surgeons face a lot of bitter experience in managing this compartment syndrome. We often see loss of life, loss of limb, and prolonged morbidity, and multiple procedures often is needed. The last but not the least slide is the take-home message. The take-home messages are: the compartment syndrome is a true orthopedic emergency, and we should have a high index of suspicion, and the clinical diagnosis is enough. Emergency fasciotomy is the treatment of choice. Both conservativeness and over enthusiasm should be avoided. Thank you very much. Thank you.
Thank you, Dr. Hello.
Hello, I'm hearing.
Hello, can you hear me?
Yes, I can hear you.
শোনা যাচ্ছে? But there my devices there is problem. Okay, thank you very much, Dr. Sadiqul Amin. Can you off your screen sharing?
Yes. Thank you.
Okay, now the question and answer. Let's start. So first of all, the question is to Dr. Professor Hassan Masud sir.
Yes.
Yes. So how long after we should not do fasciotomy?
Okay. See, yeah.
Did you get my?
How long? How long after we will not do fasciotomy? Okay. So you see, fasciotomy ideally you have to do within 6 hours, but you can maximally extend it up to 8 hours. But if there is reperfusion injury, then actually the fasciotomy is not so much viable, because the reperfusion injury cause further injury. But we have to do the fasciotomy in benefit of doubt. Though I cannot exactly say the exact time when we will not do fasciotomy, but we have to do fasciotomy to in benefit of doubt that we if we do fasciotomy, there may be some yeah, we can make some muscle viable. But actually, when the muscle ischemia begins, that means after 6 to 8 hours, within 1 hour, the reperfusion injury occurs. So ideally, when the ischemia occurs after 1 hour, if you do fasciotomy, it is not so helpful for the patient. But we have to do that. Any comment from Dr. Fazlullah Qasim? Hello? Can you hear me?
Yes. Okay, sir. What you have said, this is all right. Okay, sir.
Okay, sure. Next question.
So anyone like to?
Imon, what you have said, we cannot understand.
So anyone like to add in this about the fasciotomy?
What was the question, please?
Okay, next question.
What was the question?
Next question is about what is the how do you control bleeding during fasciotomy? Dr. Fazlullah Qasim.
Can you hear me?
Yes.
Imon, can you hear me? You can hear me?
Yes, sir.
But there is some echo. Okay. Then during surgery, in which way we control bleeding? During fasciotomy, we will control bleeding. Like that, we will hold the bleeding point and we will coagulate it with diathermy, or if big vessel or bleeding arteries, then we will hold it, cut it, and lag it with suture materials. It is nothing extra during compartment to control the bleeding. It is something like routine operation. In routine operation, in which way we control bleeding? During fasciotomy, we will control bleeding. And certainly we will not use tourniquet during do fasciotomy.
Okay, thank you, sir. The next question is, what is the advantage and disadvantage of single incision or multiple incision fasciotomy? Advantage and disadvantage. 2-5 questions, sir.
Okay, this is a very good question because we sometimes we hesitate about the aesthetic point of view. So I think by giving single incision, the aesthetic part is served. That is the is not be that scar, but we may compromise the complete fasciotomy advantages of maybe incomplete fasciotomy. So all compartment, especially in leg, may not be um, released by single incision. So in that case, double incision advantages are more because we can be sure that all the compartments are released. And if you like to do single incision in the leg, and then you have to cut the fibula. So then you can actually release all the compartments. So the advantage of single is aesthetic, and the advantage of double is that we can be quite sure and quite easily we can decompress all the compartments.
So it is better to go for that is double incision fasciotomy. That will be the answer.
Especially
Another question is
especially in leg.
Another question is regarding if a patient comes after 24 hours of development of the compartment syndrome, so what will be the protocol? Dr. Muhammad Sadiqul Amin. Can you hear?
Please again. Yes, the question please again. The question please again.
So question is that what is the protocol of treating the compartment syndrome or doing the fasciotomy if a patient comes after 24 hours of development of compartment syndrome?
Thank you for the question. And I think it is related to the question, first question given to Professor Hassan Masood sir. And I think after 24 hours, we should not think about giving a fasciotomy incision. We should think about amputation. And not only that, during this procedure, reperfusion injury can happen, and anesthetist and all precautions should be taken during doing this procedure.
Any comment from Fazulullah Kassim sir regarding this?
So, okay, what Sadiqul Amin said, this is perfect. If a patient come after 24 hours of development of compartment syndrome, then you can do only the amputation, nothing else. And you to be careful to prevent the reperfusion syndrome and acute renal failure.
I'd like to add a comment here. That is, sometimes there are doubtful cases in which cases we can feel that, especially in the leg, that not all the compartments are necrosed. So in those cases, it may be wise to carefully debride and debride all the necrosed muscles and see whatever is there. So after long debridement and plastic surgery procedures, you may sometimes save a limb. So we should consider first that is all the compartments are dead or not, or it is frank gangrene, or I think we should consider it before going for amputation.
What is the ideal time for fasciotomy, sir? This is another question. Yes.
Ideal time for fasciotomy: as soon as you will diagnose, you will do the fasciotomy. As soon as you will diagnose, you will do the fasciotomy. This is the ideal time. And doing fasciotomy after 8 hours, this is of no value. Your all the muscle, nerve will damage by this time. And what Farooq Kashem sir was saying, he is very liberal. But sir, after 24 hours, we do not expect that any muscle or nerve is viable there after the development of compartment syndrome. So it is good to pass the message to all the orthopedic residents and young surgeons that it is better to go for a amputation after 24 hours of development of fasciotomy. Development of compartment syndrome. If it is developed already and 24 hours passed.
So what is the management, post-operative management of fasciotomy? I think Dr. Hassan Masood, sir. What is the post-operative management of fasciotomy?
Actually, Dr. Sadiqul Amin said, but the postoperative management, one target to prevent infection and another target to cover the wound. So for prevent infection, you have to do the culture and sensitivity test, and accordingly you have to give the antibiotics. And for the coverage of the wound, as soon as possible, you can cover the wound. Possibly, preferably within 6 to 7 days. If you can cover the wound, that is better. And the covering by wound by secondary closure or by skin grafting or sometimes by any fasciocutaneous flap. Yes.
So far all the question is answered. So there is another one more question, that is there any role of ultrasonography or MRI of affected parts, especially in doubtful case? That is for, I think they are considering what is the in case of impending compartment syndrome, whether any role of MRI or ultrasound. Dr. Fazlul Haq Kashem.
No, there is no use of ultrasound or MRI. It is a clinical diagnosis. You can judge and you can monitor all the time. We actually in Bangladesh, we have no compartment pressure measuring device. Only meter, probably some doctors are using the catheter and the blood pressure machine to measure the compartment. If we can make it available or practice we all, then we can measure the compartment syndrome in a regular interval, and if it shows that it is increasing with every time, then we will go for fasciotomy. But if it declining after some time, then we can wait for conservative treatment without fasciotomy. But there is no role of ultrasound or MRI, and it is a very orthopedic emergency. It will not give you time to do a MRI, other than you to believe on clinical findings and you to develop this expertise. You can diagnose it clinically.
Thank you, Dr. Fazulullah Qasim. I am totally agreed with you, but I would like to add something that if compartment syndrome is suspected and an adequate examination cannot be performed, pressure levels should be measured. And monitoring of compartment pressures also is helpful in patients with altered neurological function caused by vascular injuries, continuous epidural anesthesia, or peripheral nerve injury, or in case of tourniquet palsy. In that case, you are very correct that if we have the monitoring system by weak catheter or like synthesis monitor is a beautiful monitor, or a striker needle catheter, we can measure it and take the action accordingly. Thank you.
I think there are some questions about the incision lines. I think the slide was in that gap in between the presentations. So I'm asking Dr. I would like to request Dr. Sadiq to um, describe that slide once again, so for all the viewers, please.
Hello. Can you hear me, please? Here we can see that in case of leg, the most common site for compartment syndrome, and the lateral incision is given lateral to the tibia and between the tibia and fibula, extending for as long as
Possible,
saving the superficial peroneal nerve. And in the medial side,
avoiding the sheen. Hello.
Okay.
In the medial side, avoiding the sheen 2 centimeter below the sheen margin. And from the lateral side, the deep posterior compartment must be released between the tibia and fibula. And in case of forearm and forearm, the incision line should start in the ulnar side in the arm, and then coming down around the elbow crease. It should go from ulnar to radial side, and here we should the bicipital aponeurosis should be released, must be released, and then again coming to the ulnar border, and then when going downwards in the center, releasing the carpal tunnel. Releasing the carpal tunnel and bicipital aponeurosis is very important. I think this covers it.
Okay, thank you.
Thank you, sir.
Can you hear me? Okay. So I think question is much more answered. What are the incision? Regarding another question, it is how will prevent impending or compartment syndrome in a traumatized limb or a plaster immobilized limb, or same type of question, whether about the what do you mean by impending compartment syndrome, like that? Can you answer, Dr. Sadiqul Amin? Can you answer the question? What is impending compartment syndrome, or how do you prevent development of compartment syndrome?
There is no definitive definition of the impending compartment syndrome, but this is the point which we must and which we often find, and it is very difficult to decide should I go for fasciotomy or not. The patient is painful but not too much. The pressure, the compartments are tight to feel, but not too much. Some blisters are there, but not too much. I think this is how we can define the impending compartment syndrome, which leads us to dilemma.
So I think Dr. Fazlullah Kashim like to add something.
This is all what Sadiqul Amin said. It is a borderline between the compartment syndrome and yet to develop compartment syndrome. The things is not normal. The compartment is becoming tense. It is swollen. It is more painful than usual, but yet not that it is excruciating pain on the stretching, and it is the pressure is from 15, it is increasing like 20, but not yet close the 30, like this situation.
Okay, I think we can conclude because our time is a little bit short. Now I like to give I like to request to give some speech about our today's presentation because AOLN's Regional Director Dr. R.K. Shah sir is present here. Dr. Shah sir, can you hear me? Dr. R.K. Shah? Hello? Dr. R.K. Shah?
There he is.
Yes, and I am trying to unmute.
Hello.
Hello,
Hello.
R.K. Shah.
Hello,
Good evening, sir.
Yes, good evening.
Yes.
Yes, sir, thank you. I enjoyed it.
Okay, sir. Any comments regarding the today's presentation regarding principle of management of open fracture and compartment syndrome? Any advice?
No, both topics were very good, and both topics are very relevant. And so presentation was quite nice. They have covered the topics, but few things still are debatable, like use of antibiotics. I think in open fracture, we should mostly emphasize on debridement, removal of dead and devitalized tissue. This main emphasis is on that, not on use of antibiotics, because prevention of antibiotics should be the main goal. Once we have infection is set in, once there is infected bed, then it is very difficult. So whole objective of open fracture treatment is prevention of infection, and by three things. One is thorough debridement with irrigation. Second, wound cover, fix and flap. And third is definitive fracture stabilization as early as possible. Because if you prolong with a external fixator as intermediary treatment for long, then that fracture goes into complication. So try to create a biological environment as early as possible by debridement or by soft tissue replacement, soft tissue cover. So now concept of orthoplastics are coming greatly. Now it is said that plastic surgeons should be working hand in hand from the day one in open fractures. And that shortens the complication, that saves the limb, and gives you a better result. That's number one, my comment. And then comment on compartment syndrome. I mean, once it is established, as soon as you think of it, you should do it. It's not a matter of time, 6 hours, 8 hours, 10 hours. But I agree with you that if it goes beyond 6 hours, then you are entering into a zone where recovery is doubtful. So you are losing something, either the muscles or the tissues or limb, or sometimes you may lose the patient also. So that's my comment. And compartment syndrome should be treated as an emergency as soon as it is diagnosed. Not to leave it that we'll do it tomorrow. It's not 6 hours. Let us wait until 4 or 5 hours has elapsed. Once you have diagnosed it, is to be treated. That's it. But after 24 hours, after 20 hours, when there is no pain, everything is dead, then there is no role of. So your one question was very relevant, when not to do it. So when it is already established, already gangrene, already tissue is dead, after 12 hours, after 20 hours, then just leave it. You don't gain anything by doing that. Okay, I hope it is. I have given my comments. If there is any specific, then I would like to answer your specific question if there is any.
Okay. Thank you, sir, for your comment. Thank you very much. Now I'd like to Professor Amjad, sir, to pass his comment regarding the presentation.
Yes, yes. Thank you very much for asking me to have my comments. First of all, I would just tell that the previous meetings were very, very, good in your webinar following this. The ups and downs were there very, there were a lot of ups and downs because of I don't know why it was happening, particularly when you were asking question to Dr. Fazlullah Kashem. He was not listening, but we are all listening. These sort of things are very embarrassing. And then somebody else should have been answered his question. When he is not getting the line, then you, the moderator, should ask another. There are two, three panelists are there. They should have answered this clearly. That could have been a better thing, because we are waiting, and we're not getting him through the line. And but this may happen because of the technical error. But the previous meetings were not like that. This is the first time I'm a little bit embarrassed. So I'm little according to. Thank you, Dr. Professor Ram Keval Shah, for attending and joining us to our meeting. And I'm very happy that you have commented on it. And regarding my comment, I would say that the local antibiotic controversy is there, which I like to emphasize, like Professor Ram, that no antibiotic should not be given any emphasis. It is the irrigation, it is the debridement once, twice, thrice, fourth, even 10 times, 20 times, no matter. And regarding the fixation, what you told about that initially we should go for early, for the covering the wound as early as possible, and then external fixator or better external, the modular type is better, and then go for permanent, as it is said by Kashem, that this Elizabeth external fixator if possible, which is less costly and which is available in our country too. And regarding our next paper, which has been presented nicely, but the question is again regarding the here another thing is scoring. The scoring, you see the three scorings are there. One is Gastello grading, and then two from the scoring by Gonga, and one by Mengele scoring scoring system. And the imputation should have been there. In our country, what we are facing here, the patients are coming late because they have been managed by the local people, local quacks, and then coming very late. And what is happening, our patients are moving from here and there, and we are just waiting. They are not giving consent for the amputation. But finally, lot of, loss of life as well as the limbs are there. And so we are endangering this sort of problem. So when it is late, decide that whether it is livable or not. If it is nothing is there already, gone in both this presentation, in compartment syndrome as well as in our Mengele extremity or whatever it is, when the score is more than 8 in Mengele extremity or in Ganga more than 15, 16, 17, there is no scope of keeping the limb inside and waiting for another opinion, because we need to do it immediately. Amputation, where we lost, we in my life, I faced a lot of cases and I lost the patient even. So this is my comment. And another comment, a small comment for the, sonography or ultrasonography. Doppler ultrasonogram is nowadays available in everywhere, almost in some hospitals. So we can immediately go for the Doppler ultrasound for vascular integrity. This is not a very big deal. So if possible, do it if it is available over there. And then finally, thank you so much, both the presenter and the panelist, for your comments and for your presentation. For your answer, Professor Masood, Farooq Kashem, and Fazlullah Kashem, and particularly our director, Professor Ramkabal Ram R.K. Shah from Nepal. Also, Shivastavo is there. Thank you, Dr. Mahesh Shivastavo from Nepal, for joining us, and many of the people from, I think, from Africa also joined in our last meeting today, also joining. And our MD, Dr. Claude Martin, was there initially. He told that he will be available only for half an hour. I think he left it. So thank you, thanks him also. So thank you all the participants, the presenter, and the panelists, everybody. Thank you so much.
Thank you, sir, once again for your nice comment and nice comment about the presentation. So this is all about today's presentation. And I like to beg pardon from myself because there is some technical problem maybe happen.
Yes.
So please take it, forgive me for that. And the next seminar or session will be on the next Wednesday on 24th June of 24th of this month at the same time from 3 p.m. to 4 p.m. The topic is about close reduction and basic plastic technique in fractures. So I would request all of you to participate on the next webinar. That will be the 5th webinar on 25th June. And till then, stay safe and goodbye to all of you.